On this episode of Live and Learn, Kristen Stoes explores the complex subject of Parkinson's disease with guests Dr. Alan Neeson and Dr. John Puente. Harlan Johnson and guest Dr. Lisa Mansour explain palliative care. Dolores Lintel discusses the importance of an annual Medicare Part D review with guests Houston Doan and Alicia Jones.
Welcome to Live and Learn. I'm Kristen Stoes, and this is the first segment in a three-part series on a disease that is diagnosed in thousands of patients a year in America, Parkinson's disease. We welcome neurologist Dr. John Puente, who will give us the facts and figures of Parkinson's disease and its treatment. Since no discussion of this disease is complete without the human side of the equation, we also welcome Dr. Alan Neeson, who will talk about the personal side of being diagnosed with Parkinson's. Welcome to you both.
Thank you.
Alan, could I please start with you and ask you to tell us about your very active professional career that really has encompassed two different careers?
Well, when I played basketball in college at the University of Nebraska, and then I went to Europe for 2 years and played professionally over there and finished up in the professional ranks here for about a year. So medicine was kind of my backup plan.
It's a good backup plan.
Yeah.
So tell us about your medical training.
I'm a neurotologist. I did my training at the University of Nebraska, and then at Vanderbilt I did my fellowship in neurotology. I went to Stanford for 13 years at the University at the Stanford California Institute, and then 8 years at the University of Louisville, and came back to Nebraska in 2004 and practiced at ENT Nebraska for 8 years here.
Wow, wow. So you went from being an excellent basketball player to being an excellent surgeon. What exactly do you do in the kind of surgery that you performed?
A neurotologist is an ENT person who did extra work in ear surgery, so basically putting tubes in kids, repairing eardrums, repairing hearing structures, doing acoustic neuromas for people who have brainstem tumors, and cochlear implants for people who have profound hearing.
So this is very exacting surgery through a microscope.
Yeah,
is
everything's
that true?
Microscopic, so your margin of error is pretty small.
I can imagine. So when did you first notice any symptom that you felt was unusual?
Really in 2008 I noticed a little bit of tremor periodically, once or twice a month, and I thought it was just an age-related tremor or essential tremor. I didn't know really what it was, and I saw Gary Petit, who's John's partner, and he diagnosed me as extrapyramidal syndrome and recommended I go to the Mayo Clinic for a second opinion. And I'd go up there every year, and things had been pretty stable until 2011. Then they diagnosed me with Parkinson's disease.
I see. So it did take a little bit of time to get that
It was
definite
about 3 years to get the diagnosis.
Wow. What were your first feelings when you thought you might be dealing with a neurologic disease?
Well, anxiety and fear. You know, I thought that I would lose my job, my practice, and I didn't know how progressive it was going to be and what it would mean for me to take care of my kids and my family. So, and I had a little depression associated with it too because of the unknown uncertainty of what the disease is. It progresses at different rates in different people, so there's no really way to predict what it's going to do to you as an individual.
Sure. So you really thought about others first in the beginning, I'm sure.
Well, yes. You worry about what you're going to do with your family.
Dr. Puente, if I could please bring you in at this point.
Sure.
In the diagnosis of Parkinson's, it can take a long time to make that diagnosis, or sometimes it can be a shorter diagnostic period depending upon what symptoms the patient presents with. Is this true? Can you explain that?
Sure. Well, the most common presenting feature is tremor, and so I think that in this case that was quite similar, but there really has to be a level of suspicion or thought that that's what you're thinking about as far as a diagnosis. And so, you know, sometimes when a patient maybe doesn't fit the typical criteria, maybe they're younger than a typical patient, or for instance, maybe it's a very mild tremor for some reason, then we're hesitant to make the diagnosis at that time.
Sure, sure. So what other symptoms could a person initially present with that would make them think they should see a neurologist?
Probably the most subtle symptoms are, in addition to the tremor, are going to be maybe less movement on one side of the body, and it does typically affect one side of the body primarily at its onset, and that's something that can be much more subtle, and patients might think, well, I've got some soreness in my shoulder and maybe it's arthritis, or I've got some stiffness there, and it's frequently I'll see patients that end up at the orthopedic doctors, for instance, for
Really?
evaluations and workups, for instance. But some of the other things in addition to tremor and stiffness would be slowness of movement. Sometimes even the walking can be affected in some way.
Wow, so there can be a wide range.
There can be.
Are there diseases that are similar to Parkinson's that need to be excluded along the way?
Well, Dr. Nissen had mentioned that he had initially been described as having extrapyramidal syndrome, and that's probably our doctor's way of saying that we think it's in the Parkinson's realm, but we're hesitant to put a Parkinson's diagnosis on that, and that includes some other diagnoses as well as some Parkinson's plus syndromes, for instance, where they have some similarities to Parkinson's, but sometimes their prognosis is not as good. But then there also can be other conditions that can be induced that look like Parkinson's. For instance, patients on antipsychotic medicines oftentimes can have a picture of Parkinson's, for instance, and there can be some structural abnormalities of the brain itself, which sometimes we see on MRIs or CAT scans, and that can be one way to differentiate as well.
I see. And I'm assuming that the very correct diagnosis needs to be made so that the treatment can be correct. All of these diseases have different treatments?
They do. Some of these treatments do overlap in the sense that the treatments can be similar, but sometimes the treatments are quite different. So it is important to try to discern which is the correct diagnosis, not only for treatment, but also so you can outline a prognostic plan for the family and the patient themselves so they can know what to expect and where to go.
So if someone is feeling like they are dealing with a neurologic disease, is it important for them to get a diagnosis sooner rather than later so that treatment can begin?
Well, I think there's two parts to that question, and one of which is an argument that maybe we don't need to intervene, and that is, at this point, we're not sure that we can slow down Parkinson's. Parkinson's is considered a chronic disorder. It's also considered a progressive disorder, which means once you have that diagnosis, we're quite sure of it, it typically progresses and worsens over time. So in that way, you might say, why treat earlier if it doesn't really affect the long-term outcome? But I would argue that we're hopeful that someday, hopefully soon, that we'll have medicines that will be able to intervene, slow down the condition and its progression. And then secondly, I think it is important for patients to have a grasp of what they're dealing with and be able to make some decisions about, for instance, can my practice survive if I'm a surgeon, for instance, or can I continue to be the breadwinner, and also for families to understand what the situation is so that they can be supportive.
So you can take a proactive approach.
Right.
Yes, I think that's very important. Alan, what did this diagnosis mean for you in the short term?
Well, as I was saying, I saw the neurologist once a year at the Mayo Clinic, and I'd see Gary in Lincoln once a year. And it progressively got worse, and I would notice in my surgery that I would have a little bit of tremor in my leg, and as John said, it's more on my right side than on my left side, so it's one-sided. And I'm a right-handed surgeon, so that was really detrimental to my practice. So I went to the Mayo Clinic, and we kind of decided together with the neurologist that I had Parkinson's, and I was diagnosed on Friday, and I had to quit on Monday. I had surgery scheduled for Monday, so I had to quit, because once you have the diagnosis, it's not fair for you to proceed because of the legal issues and the medical issues, and the surgery that you deal with is pretty intricate, so you don't have a lot of margin of error.
Yes, I can imagine. That had to be very difficult.
It was a shock.
Yes, I can imagine. Stress can exacerbate Parkinson's symptoms, and did you mention to me before that after you had stopped your practice, the stress was kind of lifted off you from that angle, and your symptoms actually improved for a slight while?
I think that's true with anything. Any surgeon or any medical professional has stress that they don't know about. And once I quit, I noticed that my tremor got significantly better. And the only thing I could contribute it to is not having the stress of surgery in the office and taking care of patients. And even here in the interview, I'm a little bit stressed, and I have a little bit more shake in my leg than I have most of the time. So I don't know if John would agree with that, but to me it seems to be a contributor to the symptoms.
Dr. Puente, could you please speak to stress in Parkinson's?
Sure. Well, I guess I would defer to my patients, and I think that's a commentary that I would agree with, that a lot of my patients will tell me that when they're stressed, whether it's from something like a job or an interview or even maybe a sickness, for instance. So I'll see patients in the hospital, perhaps they're getting a hip replacement, for instance, and then their Parkinson's will certainly act up, or even sometimes I'll make a new diagnosis of Parkinson's during that time. So I would definitely say that stress could exacerbate Parkinson's symptoms.
Yes, yes. Alan, you have a beautiful family, and I know you expressed that it was difficult to share this news. When did you tell your wife, Roxanne, during this process?
Well, she obviously knew that for 3 years I'd had some symptoms and it had gotten a little bit worse, so she was, well, none of us are prepared for it, but she was prepared as much as you could be. And when I came home from the Mayo Clinic, I called her on the phone and said that was the diagnosis, and that I needed to quit practice and figure out what we're going to do to continue our life, because there's changes economically, mentally, socially, physically. It's a spectrum it's a disease that covers all the spectrums.
Do you remember what her response was at that time?
Well, she was very optimistic and very encouraging and very comforting. I think she was scared, as we both were, but she didn't show it, and she showed real concern and support and empathy.
And I know telling your kids was also difficult, and you shared with me a story of how you told your son. Could you share that with us?
Yeah, my son was in Texas going to school for a year down there, and it was hard to talk over the phone, so I flew down just to make sure he knew I'd be okay. And so I flew down to Texas, and he saw me, and we went out and played basketball together and went for a hike and did everything we routinely did, so that kind of reassured him that things were okay. My daughter's first question was, am I going to be able to go to college? So, so that's kind of cute.
Well, you have a wonderful, supportive family.
You.
Dr. Puente, could you speak to that issue, the importance of a family that is supportive?
I think it's extremely important. In this case, of course, you're very lucky to have that, and I think that's definitely helped your treatment and how things have gone. And I think that families where they're able to participate in the office visits, if they're lucky enough to live close enough, or sometimes by phone call, I think once they understand that people live with Parkinson's and can have constructive lives for years, then I think it's certainly a learning process, but a relief, actually.
Yes, I can imagine that. So, Alan, obviously your professional life has changed, and how about your personal life?
I can still do everything I wanted to do. I can't operate, obviously, which is a big deal, but I still work out 5 or 6 days a week. I can play golf. I am now the medical director for the Medicaid program at the state of Nebraska, so I have some outlet for my professional activities. That's more of a desk job and a reviewing chart job, so it doesn't put a lot of extra stress on me. And personally, like I said, I can do anything I want to do, and I'm optimistic that it's not going to be very rapidly progressive. It's been roughly 4 years now, and I'm still doing well, so I'm pleased that it seems to be slow in my case.
Yes, yes, wonderful. Well, we will hope that that will continue, definitely. Did you ever have a time that you kind of said, why me? Or did depression ever?
I don't think I ever had a point of why me, but I did have some depression associated with it, because just the onslaught of what it changes your life, again, like I said, professionally, economically, socially, it's different. So I got a little depressed about that, and had to work through that a little bit. And but I think it was a natural consequence of what you're hit with, and everybody deals with something in their lives, and this is my burden. So I just deal with it the best I can.
Absolutely, absolutely. Dr. Puente, depression has to be a possibility after a Parkinson's diagnosis, or any neurologic disease for that matter. Do you counsel your patients and help them through that issue?
Well, I think that is to be expected, that when patients are given a diagnosis that is chronic progressive, like Parkinson's, for instance, there can be a period of time where it's a transition, and oftentimes depression can be part of that. And so yes, I do try to counsel my patients that this can happen. But secondly, Parkinson's also does affect the brain chemicals, and so Parkinson's patients tend to be more prone to depression. But depression is treatable, and most patients do well. Again, I think it has a lot to do with being aware that it can be a factor, and then asking questions so that it's out in the open.
Sure. Sure. Could you talk a little bit about the age range of Parkinson's patients?
Well, the biggest risk factor for Parkinson's is definitely age. As we get older, we accumulate that risk, and I think the average age of diagnosis is probably about age 60, something in that range. But that doesn't mean that patients that are 50, 40, and even 30 can't get Parkinson's disease. So we do see it, but it's definitely a lesser risk factor in those cases.
So if someone is diagnosed at an earlier age, does that affect the treatment? Are the treatment regime different for that patient?
Well, there's been a lot of talk in the last few years about treatment algorithms from the movement disorder specialists. These are the doctors that primarily treat Parkinson's disease, and then oftentimes the rest of us doctors follow their lead. And I think over the last few years it's been thought that perhaps some of the main medicines that we were using in the past, try to reserve them for later to see if we can't use them in order to prevent some of the side effects that can occur with them. But yes, in general we have several medicines that we can use for Parkinson's. They're usually quite helpful.
Alan, you were professionally trained in neurologic disease with your surgery. I was wondering, is there anything that you have found out about Parkinson's that even surprised you?
The biggest surprise is not a death sentence. You know, the fact that you have a disease and it's chronic and it's progressive is very scary and very frightening, but you can live with Parkinson's disease, as John said. And the long-term road is unknown to everybody, as I understand it. So you just have to kind of continue to work hard and play and be optimistic and do what you needed to do. So I guess the biggest surprise for me was that I can do a lot of things and still live a good life, even with Parkinson's. But a lot of it's in your mind, and you have to work on and assuring that you do it.
Absolutely. Yes, I can understand that. How do you cope day to day?
Well, I think the biggest thing is my faith in God and Christ, that I'm a Christian, and I know that God's got a plan for me. It's not the plan I wanted, but He does have a plan for me. And there's a study from the Cleveland Clinic that showed that more exercise helps delay the progression of the disease, or at least make the symptoms less intense. So from a standpoint of physical activity, I work out pretty hard 5 or 6 days a week, and I notice after I work out, my tremor does seem to be better. Now again, if this is real or not, it's just, it's what I've noticed in my individual case.
If it works, keep doing it.
Right.
And what do you see as Roxanne's and your family's role in battling with this disease?
Well, carrying on life as it is. I mean, I don't want any special benefits or anything like that. They can live their life the way they want to live their life. And there's nothing they need to do other than be supportive and empathetic. But the fact that I can do what I want to do at this time, and we'll plan to do that for a long time, I just want them to continue to live their life to the fullest.
Certainly, certainly. Dr. Puente, can emotional support actually improve a patient's symptoms? Is that possible?
Sure. Yeah, I think that goes along with the family knowledge. I think once they understand, they're able to give support. It is a learning process for the patient and their family. But I think once they're able to understand and give a positive reinforcement and be able to provide feedback and support, then the patients do better.
Alan, how are you feeling presently?
You know, I feel good. I'm, like I said, doing everything I want to do. I've got a better attitude about it, that, you know, as a surgeon, you think you can cut everything out and cure it. And I realized that you can't cure Parkinson's, and you can treat the symptoms. And I treat the symptoms symptomatically with the medicines that John had talked about. And I use them more symptomatically than on a regular basis. I don't know if that's correct or not, but I take it once in the morning, and the tremors aren't bad for the rest of the day, and then sometimes I take one in the mid-afternoon if I've got a big day or something like that. But coping is, again, an attitude, and working hard at something and being involved, not staying home, getting out and having a place to go. Keep your mind busy, because your mind plays big tricks on you if you don't.
I'm sure that's true. I know you had just one more thing to share with the viewers today, and I would like to give you the final word of our interview.
Well, I would basically have somebody get involved with a good physician like John, Dr. Puente. He's very good. And be involved with a physician that you can talk to, and he can explain the situation with you. But I think the biggest thing is the issue that it's not the end of the world, that you can deal with it, you can treat it. It's progressive, but it's usually slowly progressive. And the fact that you just need to be optimistic, work hard, and stay with it.
Thank you so much for being with us and sharing your story.
Thank you, Crystal.
It's an important contribution, and I know that our viewers will benefit from your proactive and your optimistic approach.
Thank you.
I thank you. And thank you to Dr. John Puente.
Thank you.
Dr. Puente will be back in our second segment of our 3 segments on Parkinson's to continue our conversation. And Live and Learn will return after these messages.
What does Medicare cover? How can I afford to keep living in my home? When I need help with house and yard work, who can I turn to? Why am I so tired? Am I eating right? Should I exercise? Where can I go for answers to my questions about aging?
Aging Partners is the place to call when you have questions on aging. Our experts are here to help you with unbiased answers for you or your loved ones. Aging Partners, we're only a phone call away.
Welcome back to Live and Learn. I'm Kristen Stoes, and we also welcome back neurologist Dr. John Puente. Welcome back. Thank you for being with us. Could we start, Dr. Puente, by having you tell us about your medical training in neurology?
Oh, sure. Well, I'm originally from Omaha, Nebraska, and I did all my training there. So I went to University of Nebraska Medical Center. During that period of training, actually, I thought I was going to be a family practice doctor. That's what I was familiar with growing up, and that's kind of my mentor was my pediatrician when I was a kid. But during the first week of school, we ended up cutting brains, and I thought that was pretty interesting. But where I actually cut my teeth on Parkinson's was at the VA clinic. So you do a clinic, and that's where you typically learn how to interact in the clinic and practice your first steps of medicine. And I had a Parkinson's clinic, and I really liked that, so I continue to do that.
I see, okay. This is our second segment on Parkinson's disease, and in our first segment, we talked about the early signs and symptoms of Parkinson's.
Right.
I thought we would start this segment by talking about the myriad of symptoms that can present in a Parkinson's patient over time. Is it fair to caution our viewers that not all of these symptoms happen to every single Parkinson's patient?
That's true. It really is a spectrum of signs and symptoms. So we tend to focus on what we can see. So for Parkinson's, we tend to focus on the tremor. So patients have a tremor that you can oftentimes see, and that helps us a lot of times with our suspicion of what the condition is, and then later on to measure how our treatment's going. But clearly, there can be other what we call motor symptoms or movement symptoms, and those are slowness of movement and stiffness or rigidity, as we call it. Later on, as time goes by, oftentimes the walk is also affected. We call that postural instability. So Parkinson's patients can develop difficulties with their gait, and they may be prone to falls.
I see. So can you explain the disease process and why this happens in an individual?
Sure. Well, we don't know why certain patients will develop Parkinson's, but we do know by looking at brains on autopsies that they tend to lack a chemical called dopamine. And so that seems to be a real important factor into why patients have the symptoms that they do. Dopamine appears to be the chemical in the brain that helps us coordinate our movements. And so when it's lacking, patients have this tremulous, slow, and rigid type of movement.
I see. And I understand that losing one's sense of smell can be a very early sign of Parkinson's?
Right. That's an interesting point that we've really focused on more over the last few years. And so, as I mentioned, we tend to focus on what we can see, not so much what we can or can't smell. And that's definitely something that we have noticed, is that patients often years before they show tremor can have a decrease in their sense of smell, whether they notice it or not. But that tends to be the case. And along with that same type of what we call non-movement type of presentation, patients often are constipated too, and that can be up to a dozen years before or longer. And finally, patients tend to have poor sleep. They tend to have more nightmares or more sometimes walking in their sleep, or even just moving around a great deal in their sleep, so poor sleep. And so all this kind of this presentation often predates the tremor by years.
That's very interesting. You mentioned that balance can be compromised and walking can become difficult. This is certainly difficult for the patient as well in terms of falling.
Right.
This would be a symptom that I would think a patient would want to plan ahead for, in that if they have a living environment that's not conducive to easy walking, all on one floor would be the ideal.
Right, and I think this comes where education about Parkinson's really comes into play. It's important that the provider, the healthcare provider, and the patient talk about, not only where are we today, but where can we guess what's going to happen educated guess about what's going to happen in several years from now. In some patients, they have trouble walking years after the initial diagnosis, and that's, of course, what I would prefer, of course, for my patients. But some patients, unfortunately, progress quicker. In those, it's really paramount that you talk about these things in anticipation of them.
Certainly.
And monitor those. And yes, so you can make the changes necessary at home or at work or otherwise to make a safe environment.
Be a little more proactive.
Right.
Can there be vision changes associated with Parkinson's?
There can be vision changes. Now, the actual visual acuity, as we call it, where how well you actually see, may not be affected as much, but typically what's affected is the movement. So again, we get back to the movement of the eyes. The eyes need to move together. And so when you're reading, for instance, it does require that there's coordination between the movement of the eyes. And so patients often will complain of kind of a herky-jerky type of movement when they're trying to read, or sometimes when they're watching maybe something where there's more action on television, for instance. They'll say, I can't track that as well. Sometimes they'll have dry eyes just simply because they're not blinking as often. They'll complain of dry eyes as well, so that can also happen.
Okay, that all makes sense. And handwriting changes?
Handwriting does tend to change. It's a curious phenomenon where patients tend to write small. We call it micrographia. And it probably is the patient's way of compensating for poor control of their pen or pencil. And so they'll have more control if they write smaller. So we call that micrographia, and we oftentimes see that if we get a sample of the patient's writing.
Oh, I see. All right, that makes sense too. How about a patient's ability to speak?
Patient's ability to speak sometimes is affected as well. Commonly, the family will come in and say, Dad isn't speaking very loud anymore. He's got a quieter voice. I have to ask him to repeat himself. And we do see that in Parkinson's, and perhaps has something to do with the way the vocal cords don't move as well. Again, getting back to the movement issues. So they tend to speak with a raspier, quieter voice. Yes.
And as the disease progresses, can eating be difficult and swallowing be difficult?
Right, and these are some of the, typically one of the more later and progressive stages where patients may not swallow very well. Again, dependent on how the muscles in the throat contract together in order to get food from the mouth down to the gut. And if they don't work very coordinated, we can be prone to choking, sometimes even on our own saliva as opposed to food itself, and that can be very problematic.
Yes, I'm sure. I've read that impulsive or compulsive behaviors can be exhibited by a Parkinson's patient. Can you comment on that?
They can. In Parkinson's itself, sometimes we see that patients will have impulsive behavior. Sometimes it has to do with sexual behaviors. Sometimes it has to do with gambling behaviors. So basically behaviors where the patient's trying to accomplish pleasure. But typically we have ways of saying enough, moderation, pleasure in moderation. But another time that we see this is the medicines for Parkinson's. So there's certain medicines in Parkinson's we see a higher incidence of this. And so the combination of having Parkinson's and being treated for Parkinson's can sometimes make patients at risk for this behavior.
Wow, I had never heard of that before. Is there physical pain associated with Parkinson's?
Pain is magnified by Parkinson's disease. Okay. So, I would say it's pretty unusual that most patients don't say they have pain on occasion, whether it's arthritis or maybe a chronic ailment. But those with Parkinson's tend to complain about it more commonly, especially if it's not controlled well. So I have found that when patients have chronic pain, whether it's back pain or arthritic pain, that if their Parkinson's is controlled better, they tend to complain about it less.
I see. Can there be bowel or bladder involvement?
Well, we talked about how constipation can oftentimes be an early sign of Parkinson's disease. So we very commonly see constipation. I would say most patients have a degree of constipation as well. And again, that also can be worsened by medicines. Bladder, I wouldn't say is typically real commonly associated with Parkinson's, but as men typically tend to be more affected with Parkinson's, we do see some bladder issues there too.
I see. All right. How about fatigue or sleep disorders?
Fatigue, definitely. Parkinson's patients tend to be tired. Again, especially when they're not optimally controlled. They spend a lot of extra energy with their tremors, so shaking, and also with their stiffness. So they have to overcome that. Typically when they're maybe more physically stressed, they tend to tremor more, and they'll try to control that, and that causes fatigue. So that definitely we see that.
Can the cognitive function in a Parkinson's patient diminish over time?
It can, and this is maybe something that we can't see. So again, one of the non-motor symptoms, and the non-motor symptoms tend to be even more difficult to control, and this is one that we certainly worry about with Parkinson's patients as they progress, that their mental faculties may not be as strong. They may become more forgetful. They may tend to have poor organizational skills, for instance, and so those are things that we have to track by talking to family.
Is the progression of the disease different in every individual?
It really is. It really is. Again, we can talk in generalities. Typically, most patients live with Parkinson's for years, as long as they take their medicines and are able to control their symptoms. Yes, the medicines tend to lose some of their efficacy or how well they work over time. We can usually make adjustments and keep up with that. But some patients do progress quicker, and it's definitely more of a challenge.
I see. Is there any truth to the statement that Nebraska has one of the highest incidences of Parkinson's cases in the world?
It is true. It is true that here in Nebraska, we do see a large amount of Parkinson's disease, and there's been a lot of speculation as to why that's the case. We see and think that exposures to pesticides, and for instance, and maybe heavy metals in our environments may make us more prone. But clearly that's not the only reason, because some others that may live in the same community may have the same exposures and not get Parkinson's. But we think there is an association.
So environmental factors can play a part in Parkinson's disease.
They do.
Is heredity an issue?
And heredity is also an issue. We do see in our studies that there can be, but rarely, Parkinson's where multiple family members have the disease in multiple generations. More commonly, it's a lesser component of a risk for Parkinson's if a first-degree relative, as in mom or dad or brother or sister, have Parkinson's, but it's probably a part as well.
Okay. I had also heard at one point that smokers have a decreased incidence of Parkinson's. Is this true?
They do. They do. For some reason, smokers, we spend a lot of time telling our patients to stop smoking if they do,
exactly.
or not to think about doing that. And so, we look at it differently for Parkinson's, where it seems that if you do smoke, you have about half the chance of getting Parkinson's as someone who doesn't. So in that way, it does seem to have a protective mechanism. But nonetheless, unfortunately, all the negative aspects of smoking make it so that we do not suggest smoking for Parkinson's.
Certainly, I understand that, but it's an interesting
It is interesting.
pairing, yes. Men versus women, is sex a determining factor in some way?
We do see women that have Parkinson's disease, but clearly men have it much more frequently.
Really?
Almost twice as often men will have Parkinson's than women. And we don't know exactly why. There was a thought that there may be some hormonal reasons for that, but there is no clear reason at this time.
Let's shift our discussion to treatment options for the patient. Are there good medications to help alleviate the symptoms of Parkinson's?
There are excellent medications to help alleviate particularly the motor symptoms. So again, the symptoms and signs that you can see. Tremor is almost always controllable with the appropriate medications. And there are several different medications to choose from as well. There really isn't a right or wrong order of how you use them. There have been some tendencies that I think that have maybe become more common over the last few years, but I think the main thing is that patients, if they have symptoms that can be controlled by medicines, they should be on medicine.
Certainly. And once the medications have been started, is there an effectiveness timeline to the medications?
Well, there is a timeline. Unfortunately, it seems to vary from patient to patient.
All right.
I think, again, talking about averages, typically patients can be on one medicine for several years before they have to add, and typically do add a second medication and sometimes a third, and unfortunately sometimes more than that. But I think the good thing about that is that usually it does control their symptoms.
So continued monitoring of a Parkinson's patient is extremely important.
It is important to be seen at regular intervals to monitor how the treatment's going, and if any new problems are arising.
Certainly, certainly. Could you speak to the issue of good nutrition for a Parkinson's patient?
Good nutrition is, of course, good for all of us, but in Parkinson's we pay attention, especially because they tend to be constipated. So I usually spend time with my patients to tell them how are your bowels moving and what can we do to keep them moving if they are already, or if they're not, what we can do to maybe supplement with fruits and vegetables and fibers. I think those are very helpful. But as far as a Parkinson's diet, I think there have been some thoughts to maybe there are certain supplements that we should be adding to help either slow down or modify Parkinson's. We really haven't come up with a consistent supplement that I would say that we are
So no
suggesting.
definite vitamins that you can cite to be...
Right.
Okay,
right.
all right. And how about exercise?
Exercise is very good for Parkinson's patients. Again, I think if you look up classically in our books about Parkinson's, we didn't spend a lot of time talking about exercise. This is probably a newer component to our treatment. But I think you'll see now that we think that exercise can create new circuitry in the brain and really be helpful for Parkinson's patients who particularly struggle with things like balance. And so I think that that's something that we encourage our patients to do, is participate in physical therapy and perhaps some of the other disciplines that can help with their balance.
Yes. Are you optimistic about the future of Parkinson's and the development of possibly new medicines, maybe even a vaccine?
I think it's an exciting time right now for people who have interest in Parkinson's and for Parkinson's patients. Even in the last 10, 20 years, we've seen a lot of new medicines come around. We've seen a lot of focus on Parkinson's. The vaccine, for instance, is a completely different way of looking at Parkinson's. As opposed to treating the symptoms, it's a way of maybe preventing Parkinson's from occurring or slowing it down. And I think that's our next step, not only treating the symptoms, but finding a way to intervene, and that's a very exciting prospect.
Yes, that would be very exciting for sure. Our third segment will be featuring your associate, Dr. Ben Gelber, who is a neurosurgeon and who specializes in deep brain stimulation. And he will talk at length about that, but I wondered if you might offer just a word about it.
Sure. Well, deep brain stimulation is reserved for those patients where medicines are helping, but they're not helping for very long. So we call that on-off phenomenon. And I'm sure Dr. Gelber will go into some detail, but it is an alternative for patients should they choose. And again, as long as they have pure Parkinson's and that their medicines just aren't having the effect that they used to.
I see. Well, we will look forward to hearing from Dr. Gelber, and we thank you for being with us again today, Dr. Puente.
Great,
I know your expertise has helped many of our viewers.
I appreciate you having me. Thank you.
You are very welcome. We hope that you will tune in to our third segment on deep brain stimulation with Dr. Ben Gelber. And Live and Learn will return after these messages.
What does Medicare cover? How can I afford to keep living in my home? When I need help with house and yard work, who can I turn to? Why am I so tired? Am I eating right? Should I exercise? Where can I go for answers to my questions about aging?
Aging Partners is the place to call when you have questions on aging. Our experts are here to help you with unbiased answers for you or your loved ones. Aging Partners, we're only a phone call away.
Welcome back to Live and Learn. You know, in the Living Well magazine, put out by Aging Partners, this month, there's an article by Dr. Lisa Mansour on palliative care. Now, I must admit, I wasn't quite sure what all that meant, so I looked it up in my old college dictionary. Now, that really wasn't archaic that much, but it was an old dictionary, and it was in there, so palliative care is not something new, and we're going to talk about. Dr. Mansour, thank you for coming and being on the Live and Learn show and presenting some of your knowledge about palliative care.
Well, I appreciate being here. We love the opportunity to talk about palliative care.
Now, how long have you been in practice here in Lincoln?
I have been practicing here in Lincoln for 9 years.
Okay.
I'm a critical care doctor, and a lot of what we do in critical care is actually palliative care.
All right, and you just brought up that word. What is palliative care? Let's explain it for our audience.
Absolutely. Palliative care is really a process of medicine, a path of medicine which is devoted to the last generally 2 years of life, when we know that cure and often even restoration aren't possible. So our focus in palliative care is to promote as much quality, dignity, and comfort as possible.
Well, I noticed in your article you talk about that 25% of the Medicare funds are spent on the last part of a person's life.
Yes, that's exactly right, and that's really been a change over the past several years. And I would argue that we obviously need to spend more time focusing on the things that are most important to our patients and their families.
Well, who might be a candidate for palliative care then?
Great question, and of course a lot of our work is done at the hospital, but we're working on the process to spread this to the community. But in general, if we look at our patients and say, you know, I would not be surprised if our patient wasn't here in 2 years, they're a good person to start those conversations, even in small 5-minute snippets. People who are repeatedly in the hospital, those individuals that say have been in the hospital 3 or 4 times, or even in the ER 3 or 4 times in the past 3 to 6 months, it's time to have a good, solid conversation about the path ahead. Individuals who have chronic illness or a rapid decline, those folks are absolutely candidates to sit down and have conversations with.
Now you talk about candidates, and that's a good, who probably should initiate the, let's talk about palliative care? Should it be doctor, or the minister, the patient?
Absolutely. And you know, our goal is to empower everybody to have these conversations, because the final phase of life is a very important phase of life, and we should really focus on not medicalizing that phase, but using that phase of life as a point of growth. And so the answer to that question is we all should be having those conversations. Our primary care doctors, our pastoral and spiritual support folks, and even families. We'd like to empower both patients and families to feel very comfortable initiating those conversations.
Yeah, I can see where it's a whole team. Well now, where do we usually administer palliative care?
Currently here in Lincoln, Nebraska, what we've done is focused our main efforts at the hospital. So we work very closely with our hospitalists within the hospitalists and our hospitals and our subspecialists to work to start those conversations in the hospital. But now we actually have a clinic where we can go to homes, we can go to living facilities, we can go anywhere to start those conversations. So even though the majority of our practice now is in the hospital, we're trying to spread the word.
And you raised my next question. When is that magic time? When's it time to start?
Right. And if an individual is feeling that their health is declining, or if a family looks back and sees that there's been a path of decline, it's time to start having those conversations. And how do we have those conversations? You know, the biggest question we get asked is, hey, what do you expect, Doc, to happen from here? And although only God knows how long we have on this earth, there are definitely some evidence-based things medically that help us know what's coming in the path ahead.
All right. Well, obviously, palliative care to the patient and the patient and doctor relationship is very important. Why is this so important?
It's important because what we found is being very aggressive and promoting a lot of interventions as we approach end of life, those things really aren't adding to quality or comfort. In fact, not only are they adding to the cost, like you mentioned earlier, a lot of times they're adding to suffering and discomfort. So as we step back and look at things in a forward fashion, we're finding that as we focus on symptom relief, comfort, worries, dignity, all of those things, that's promoting a longer and more comfortable life, not only for our patient, but for their caregivers and family.
All right. How do you initiate then palliative care? Where do we start?
Great question. And in the hospital, what happens usually is either the patient, the family, or our hospitalist. So our specialists in hospitalist medicine ask us to come by and start those conversations about where we've been clinically, where we're at medically, and that helps us determine the path forward, and then we can present what options we likely see ahead. So the answer is the patient can ask for it, we have families ask for it, and we also have our doctors ask us to come by and initiate those conversations. Those conversations are basically by just introducing ourselves, explaining what palliative care is, which truly is, as you mentioned, something that's been around for a long time, but maybe not formally called palliative care. It's old-fashioned medicine. It's where we really sit down with patients and families and help them understand the options ahead.
You said the magic word a while ago when you said quality of life.
That's correct.
And that's what we're looking for
Absolutely.
at this time in a person's life.
Absolutely. And when we sit down with patients and families, you know, without question, there are 4 things that our patients ask us for. And number one is they want to be the boss. They want to make sure that we as physicians and that their families know that they are the ones that are scripting their care in the final phase of life. The second thing they ask us for is they really don't want to deal with any pain, just like any of us. Third thing is they want no suffering. They don't want to be short of breath. They don't want to be nauseated. And then finally, because they're devoting so much of their energy to, you know, what's going on with their own bodies, they ask us to help their families understand what's going on.
And obviously certain medicines just counteract just what you said.
Mm-hmm. That's exactly right.
And doing that. Okay.
That's right.
All right. Well, I've learned how to spell it, and people need to understand and find out where they can plug into palliative care.
That's exactly right. And we're here in Lincoln at the Bryan Health Systems. We go to Madonna. We're available in the community. We've also reached out to some of our spiritual leaders in town. We're happy to talk with you know, folks in their churches where they're comfortable and feel comfortable asking the questions that need to be asked.
Okay. Now, the players in palliative care, and you can name them, I'm sure, but we're talking about physicians, we're talking about pastors.
Right.
Who's all involved in that team?
And as you mentioned early on in our conversation, it is absolutely teamwork. It involves the physicians, our nurses who are terrific advocates for our patients. It involves nutritionists. It involves physical therapy, anything, anybody, any way that we can maximize and improve the quality of life for our patients.
All right. Well, you've done a very good job, and I'll bring up the article again in the Living Well magazine where I first read the article, and I thought, this is impressive. We ought to have her on our Live and Learn show and talk about this, because this is something that we actually need to get out there so that the general public is more knowledgeable.
Absolutely. We'd like to empower everybody to ask about it, because it's not a matter of telling people what to do, but it's allowing them and empowering them to understand the path ahead.
All right. Well, Dr. Mansour, thank you for coming and being on the Live and Learn show, and thank you for your article in the Living Well magazine, which was very good. So thanks for being on the Live and Learn show.
Thanks for having me. I've appreciated it.
All right. Live and Learn. We'll be back right after this message.
What does Medicare cover? How can I afford to keep living in my home? When I need help with house and yard work, who can I turn to? Why am I so tired? Am I eating right? Should I exercise? Where can I go for answers to my questions about aging?
Aging Partners is the place to call when you have questions on aging. Our experts are here to help you with unbiased answers for you or your loved ones. Aging Partners, we're only a phone call away.
I'm Dolores Lintel, and I have as my guest today Alicia Jones, who is the coordinator with the SHIP program with the Nebraska Health Department and Insurance Department, and I have Houston Doan, who is a insurance consultant with Aging Partners. And we're going to talk today about the Part D and Medicare Advantage changes that are coming down the line and how seniors can get help to respond to those. I should tell you that there will be an article in the upcoming Living Well magazine that is published by Aging Partners that will also be helpful. And throughout the program, we will have on our screen phone numbers that you can call to make appointments to get help, and also a schedule of the clinics that will be held throughout the community that you can attend to get good, useful information. So we'll start out by just putting out the information there and getting some ideas out there for the people. What are the enrollment dates of the changes?
Well, each year, October 15th through December 7th is the time for people to reevaluate their options. And during this time, they can check their current Part D plan or their current Medicare Advantage plan. They can check the new options, and if they'd like to switch, this is the time to do it.
Okay, and can you identify any of the changes that are coming that they need to respond to?
Every year we see changes with all of the plans, whether it's premium changes, maybe the premium went up a few dollars, sometimes they go up pretty drastically. Co-pays can change on your drugs and deductibles can change. The other thing to look out for is sometimes the plans will go through and drop drugs. So maybe this year your drug was covered, next year it might not be.
Okay.
And of course, if you're in the Medicare Advantage plans, this is an opportunity to reevaluate those Advantage plans and to make some educated decisions on do you wish to continue on that particular kind of coverage, or you may want to return to original Medicare and then pick up a standalone prescription drug plan.
I see. Well, I think as we age, we like to have the feeling that we have made some good decisions and that they are in place and we don't have to worry about changes and new things coming along. So all of this becomes very confusing and frustrating for us. So it's good to know that there's help available, and that's where you two come in. So tell me what you can provide to the seniors and how they can access your help.
Well, during open enrollment, we have about 300 counselors across the state. In Lincoln, we have about 80 counselors. And what you can do is you can come into our office, you can call our 1-800 number, or you can come to one of our enrollment events and sit down one-on-one with our counselors, and we'll go through the options with you. We'll take the list of your drugs, put them into the computer, and then we can see how each plan out there will cover them. We'll compare your current plan to the new plans and just educate you on what the options are out there.
Okay. There's so much information that's given out at those clinics that it tends to be overwhelming. So I think the part where you say we'll sit down with them individually and consult and review and make decisions, that to me would seem very helpful.
Absolutely. Yeah, just having a person there to help explain the options will take as much time as you need. If you need 15 minutes, if you need an hour, if you want to go home and think about it and call us back, absolutely, those are all options.
Yeah, I think being able to go home and think about it too, because you want to be so sure that you're making the right choice. At that time in our lives, so many of us are already facing a chronic health condition, and we don't want to jump into something that looks good because there's a lower premium or we think there's a saving somewhere and then have it the wrong decision and not have the adequate coverage. So I think the individual counseling is so important.
And the Aging Partners will also offer that kind of individual one-on-one. Our clinics, if you want to call them that, are pretty much all the time. We have people there throughout open enrollment that can help individuals with questions, reviews, or sometimes we get people who don't even know that they have these options available, and then it gets to be not only an educational process, but then also a choice for them, and that is sometimes, as you pointed out, very hard for older adults to make these steps because they do feel like, well, I've made the decision once, why do I have to do it again?
Do you think it's helpful sometimes for them to have someone come with them, say one of their children, or someone as just an extra ear to listen to the options and help them to make those choices?
You know, I would say it totally depends on what that person's comfortable with. Some people, want to do it all by themselves and understand it. Some people do prefer if maybe a son or a husband, wife come with them, just to make sure they're understanding it the way that they need to.
Okay.
Yeah, and I actually have children of older adults that call me every year and say, Mom's still in Scotts Bluff. We're here in Lincoln. I want to make sure she has the right coverage. We can help those children of the older adults, even if mom and dad are out of town.
Well, or sometimes if you're older and perhaps not feeling well, this isn't something that comes into your scope of things I have to do by the end of the month or something. And so it can become easily overlooked or just laid aside for a later time to deal with it. So give us again the enrollment dates When is the deadline? When can they start, and when is the deadline when this has to be completed?
Well, October 15th is the first day that you can actually switch. Now, the interesting thing is that you can pick a plan for next year, but that new plan will not start until January 1st of the upcoming year.
Okay.
And then they have to December 7th, but last year they changed the law, and if by some health problem or something happens and they find that that prescription drug plan that they picked isn't working, next year they are allowed to change up their plan one time, anytime during the year. Now they are limited. They have to pick something called a 5-star plan, but it is what I call a kind of an ace up their sleeve. That is, you're not locked in. So if your health should change and you, let's say, get a lot more prescriptions, this may be something that they need to be aware of.
Okay. Now, in making these decisions, sometimes you're able to save them considerable amount of money over what they've had in the past. Is that correct?
Yeah. We were talking yesterday, and Harlan Johnson, who's another guest on Live and Learn, he reviewed his last year, wasn't that right? And you said he saved something like $600. Well, now, that's a lot of money to me. You know, that's $50 a month. That could be a water bill.
Well, and it's something that, as an ordinary citizen, reviewing all the input that you get, either on the mail or on television or other sources, you may not be aware of the fact that this one is actually the best for me and can save me more money than the rest
you're
of
absolutely correct.
And I would say that's, one of the reasons it's so important to go out and check. I know last year we had a new plan come out and it offered free generics. So we had so many people switch to that plan and saved, depending on the person, between $200 and $600 a year just because they reviewed.
Okay. Is there any help available for low-income citizens who need help with their prescriptions or any other service that you have?
There is. There's a program out there. It's called Extra Help, or a lot of times we refer to it as LIS, and it's through Social Security. And what the program does is if you meet specific income and asset guidelines, it will help you pay your Medicare Part D cost. So it'll bring down those premiums, it'll bring down the co-pays, and help you cover that deductible.
Okay.
And then going a step further, if you happen to be lower income with lower assets than what we call the LIS program, you may actually be eligible for something called QI-1 or actual Medicaid, and the Aging Partners office is there to help people through that process. And that can be very, very helpful for an older adult on a fixed income, where we can actually not only give them a free prescription drug plan and $1.60 copay up to about $2.60 for brand name. So I mean, very inexpensive.
Yes, really.
And depending on their situation, we can actually get their Part B, as in boy, premium paid as well, which would give these eligible individuals an additional $99.90 this year back in their Social Security check, which of course could be very helpful for an older adult on a fixed income.
So all of this could be discussed if they call and make an appointment to come in and review what they're doing now, the options available, and the decisions to be made. All that information would be put out there for them, so it would help them with that as well.
Absolutely.
Okay, and the phone numbers for both Houston and Alicia are up on the screen throughout this broadcast, and I hope you take advantage of it. They've given us some really good information today.